Hi everyone, this is Dr. Palden Wang connecting to you from Gangtok, Sikkim. I'm a practicing cardiologist, interventional cardiologist, and today I'm going to discuss one important case to you all, which is very common in our daily basis. So this patient is a 52-year-old female, Martina, who is a very nice and wonderful woman, and she was diagnosed with type 2 diabetes 9 months ago. In addition to that, she also has hypothyroidism. And 9 months ago, she was prescribed metformin of 1 gram twice daily and levothyroxine of 100 microgram once daily. So with this, she was very robust with her lifestyle modifications, and she used to exercise about 5 to 6 times a week. And in the initial first 3 months, she lost around 6 kg, and then subsequently she lost another 5 pounds. And this time she had presented to us with her lab reports, and we saw that her HbA1c had decreased from 8.1 to 7.8. Her current EGFR is around 88, and her LDL cholesterol is 80, HDL cholesterol of 34, triglycerides 150, TSH of 1.7, and AST of 33. Currently, her BMI is still above 30, and her blood pressure is 120 over 70 millimeter mercury. Her heart rate is around 85. So this is a very, very common scenario in our day-to-day practice, where we find patients who have received the initial treatment, and despite of that, they are still above in their HbA1c goal. And it is very important to highlight here that it is very intensification of treatment should be done on time, because we have to achieve all the glycemic goals very early. And there is this thing called glycemic memory, which is very important, that if we control the blood sugar very early in their disease course, we tend to give them the benefit over the period of time and over the lifetime. And so in also this, there's guidelines by the American Diabetes Association, where they have said that if the initial HbA1c is more than 7.5, then the goal should be to bring the HbA1c below 6.5. And our patient, who has although followed all our lifestyle modifications, she has changed her diet, she is exercising 5 to 6 times a week, there is some inertia regarding her treatment. We can see that she has been given only metformin of 1 gram twice daily. Now this is a time that we have to think seriously about reducing her cardiovascular risk in future. So we have to offer something which is going to give her benefits in the long term, especially in the cardiovascular scenario. And so that combination treatment is very, very essential in type 2 diabetes, because when we combine treatment, we are targeting different metabolic defects. And also the fact that diabetes is a very progressive disease, although it progresses at different rates in different individuals, we have to ensure that we are introducing some disease modifying drugs in their early course of the disease. And also because single drugs are sometimes having a very limited efficacy, and also combination therapy can potentially preserve beta cells and also give a durable response compared to monotherapy. There has been a trial, which is the ADOPT trial, where we have found that when we give monotherapy in patients, the discontinuation rate is quite high. In the ADOPT trial, we have seen that 15% of patients on rosiglitazone, 21% with metformin, and 34% with the sulfonylurea, they tend to discontinue their therapy. And although we have seen that this patient did continue all her medications, and she did not fail in her treating her disease. So it is particularly this clinical inertia with the clinician, because of the fear of hypoglycemia or weight gain. This has led to poorly controlled glycemia. There has also been a recent retrospective cohort study where they have shown that in patients who are having HbA1c of more than 7, it took around 3 years to intensify the treatment from 1 to 2 oral antidiabetic agents. And we all know that early glycemic control leads to better outcomes, including a reduction in long-term macrovascular or microvascular complications. So for patients with inadequate glycemic control on metformin, addition of the single pill might be considered to establish optimum glycemic control while reducing pill burden and avoiding clinical inertia in intensifying therapy. So when metformin is not suitable, we have an option. One such option is the empagliflozin and linagliptin combination, which can be an alternative first-line therapy, particularly in patients with HbA1c which they have not received. And also, according to the 2020 ADA guidelines, they have said that control of glycemia and cardiovascular risk factor management is very, very important. So we have come a long way from making and marketing drugs in the arena of diabetes. Initially, the target was only on reducing the numbers, but now we are making drugs which are actually benefiting the cardiovascular system and reducing the future ASCVD events. So there is a clinical evidence, recent clinical evidence, when that the combination of SGLT2 and DPPO inhibition is an effective option for management of type 2 diabetes. And as we all know that this combination can help the patient not only achieve the HbA1c goal but also achieve other goals like blood pressure and weight gain. In another phase 3 randomized trial, there has been a investigating efficacy of safety of empagliflozin and linagliptin. There was a better tolerability observed in subjects who were receiving the combination compared to those who were receiving empagliflozin alone, and there was no difference in terms of serious adverse events like hypoglycemia and genital infection. So this implies that empagliflozin and linagliptin combination can be a substitute or as an add-on therapy to metformin to provide additional glycemic efficacy in uncontrolled patients. Thank you.